outreach and engagement. She serves on a number of task force and advisory committees focused largely on preventative health services and related programs. And today she'll be talking to us today, looking at using implementation science to advance health equity.
Thank you so much. Appreciate it. It's good to be in the building of my alma mater from medical school, Rush, and I've done the circuit around here. So, I did undergrad at University of Chicago, my epidemiology MPH at UIC, Rush for medical school. I did clinical training in OBGYN and fellowship in family planning at Northwestern, and I stayed on as an attending. I did my OBGYN residency at Yale, so I did the circuit. In any event, today we're going to go over some definitions because I never assume everybody is on the same page, and then really think about design thinking approaches, which I call implementation science, and how they apply to understanding and helping to improve health inequities. Because I really do think implementation science is an important strategy to ensure that our structure and design of healthcare delivery is actually equitable. Back in the day in grade school or junior high or something, we all learned about the animal cell and what really makes an animal cell thrive as opposed to, apoptosis or turn into a malignant cell, right? And each of those parts, right, has to be able to be in an environment that allows it to thrive. And then each of those parts has to do its role, and then they have to do it together, right, as an orchestra to make a symphony, right? And that's really critical to understanding implementation science, because it's about the design and the structure and the process to get the phenotype or the thriving that we want, right? So that's how it starts. And we know basic math, basic models. Garbage in, garbage out. Good stuff in, good stuff out. That's about all the math I know. I hire everybody else, but that's really important because what you put in is what you get out. If you're a bench scientist, early translational T0, T1, or you're the most applied scientist, T3, T4, right, or at the bedside in a clinical trial, who participates, where you get those specimens from, what are the exclusion and inclusion criteria? That all impacts what you get out and how applicable or not applicable that clinical trial or models are. And that's really from my perspective on my 5 years at the United States Preventive Services Task Force with all of those issues of modeling and the processes that lead us to recommendation statements for preventive services for the nation. It's the same thing. You gotta, just like the late Congressman John Lewis said, you gotta look under the hood of the car, even if it's a frunk, right? The all-electric Tesla, right? You got to know what's there to make the engine drive. So why we use the word equity and not equality. In the upper left-hand corner, so I'm using a tree to, depict something that is a man-made process, all right? Inequities, structural racism, systems of oppression are human-made on other humans. But I'm just using a tree that's an organic structure. But if the process, whether it's a search committee, an admissions criteria on an admissions process, a protocol for a clinical trial, a research study design, whatever it is, a law, a policy, if it's fundamentally created bent, right, meaning it's advantaging some people and actively disadvantaging others, then you're not going to have a chance at justice. You're just not, all right? So if you look on the upper right-hand corner, I hear even to this day in 2023, well, equality, everything's equal, equal, equal. No, well, then it's equal and everyone would get the chance to get an apple if the fundamental process wasn't bent advantaging one population or group of people and actively disadvantaging another, right? But if the process is bent, or that policy or practice is really favoring some over others, then equal doesn't work, right? And so in the lower left-hand corner, an equity model, you understand that the process is fundamentally bent, and you might be trying to change that policy, practice, law, way admissions criteria are, et cetera, but you acknowledge while you're trying to change that, you're giving everybody a different lift to get to that apple, to get to that goal. All right, and in a justice model in the lower right-hand corner, you really are asking the fundamental question: why is the darn tree, policy, practice, et cetera, bent in the first place, right? And that's how you seek to unbend that tree. Okay? Now we're all on the same page, hopefully. So root causes, right? Social determinants of health are driven by systems of oppression. Racism is not a social determinant of health. It's oppression, systems of oppression, all the isms, racism, et cetera, isms are fundamental causes of diseases. They are the most upstream, and they drive what has created social and economic and political factors that then influence whether somebody has good health or access to good health or access to care versus poor health or in conditions that drive poor health. Okay, so David Williams, back in 2019, still has a really good figure in health services research, the house that racism built, and really how in that basement of that picture, psychological responses, biological processes, behavioral responses, healthcare use responses, like distrust and everything, individual and collective responses, all get under your skin, right? They all impact things like the weathering hypothesis, right? Arlene Geronimo, she has a new book that just came out, and other things that drive health outcomes. All right. We always have to look historically in order to move forward. We have to understand what's been going on and then move forward. We know that we have a long history, deep, long history of oppression, slavery, racism, and discrimination. In my own field, J. Marion Sims, the father of American GYN, so-called, vesicovaginal, rectovaginal fistula repairs done on unanesthetized women, completely egregious, right? Lucy Anarcha, Betsy. And then we've had bath riots, just across the border in early 1900s. We used to have a disinfection process for people coming from Mexico into the United States to work. And they had to undergo vinegar, kerosene, gasoline washing, disinfection before they came to work in our own country. And so Carmelita Torres, who was age 17, she started the bath riots by refusing to disembark from the Boston Submit, right? And then we've got Puerto Rican women who were basically tested on or experimented on to make the modern day birth control pill in the 1950s. So that wasn't that long ago, right? And some of us were alive during that time, right? And forced sterilization, not only in the 1970s, but forced hysterectomies in 2020. So what we also have, as you all know, is the COVID-19 pandemic that we're moving out of, exposed a lot of existing health inequities and exacerbated across the board. And I would really say that now more than ever, and probably in my entire lifetime, is probably going to be the most impactful time that we have in healthcare delivery and also in science to actually build back trust, right? We lost trust of people over all these years and all this history, right? So now we've got this issue that has been the issue of trust and disinformation that has been made even worse with the pandemic and politics and all those other things in the media right now. We have the opportunity to build that trust back in science and healthcare delivery, and I think this is our time. So it's a really exciting time to be a scientist and a healthcare provider, I would say. But we've got to focus on things that will do this, right? That will address disinformation, that will address distrust, and that will bring trust back into science and healthcare. So another way of saying this, and this is very true to Chicago. I mean, I've been here since 1990, and I was an epidemiologist in the Department of Public Health with Dr. Steve Whitman for a few years before I went here to medical school. And really, the whole thing about this tale of two cities, right? This is a Chicago thing. It's an urban thing. It's also a rural or suburban urban thing. why are there two cliffs, and why are, in my picture, why are the people who are depicted in the color green starting at the edge of the cliff with no fence, no safety net, no ambulance, right? That systematically excluded, oppressed population that some people call at risk. I don't like to use that word. And that's really driven by those systems of oppression. And it puts the people who are on the green color on that cliff more disadvantaged with respect to those social and economic and political factors that influence health that I put in those little boxes, right? So the research pipeline. I do a lot of work at NIH. I'm on an advisory committee at the Office of Research of Women's Health. I do a lot at the National Academy of Medicine as well. And this whole process of doing research is very biased, right? Starting with the funder, right? If you think about it, when the funding opportunity is created, the team that's going to write the application for the funding opportunity is going to do what that application is requested, what that funding opportunity says. So if the Cancer Center Support Grant, thankfully, NCI has done something good, requires a strong commitment to community with the community outreach and engagement. And now they require another component called DEI, diversity, equity, and inclusion, right? Now the Cancer Center directors for comprehensive cancer, cancers across America who are applying for the CCSD grant, which is a big deal, will then make sure that they're paying attention to the community outreach and engagement component, right? And making sure all their research and all that work is connected to the catchment area. At Lurie Cancer Center, for example, we have a 9-county catchment area, which includes some rural and lots of suburban, and then Chicago's Cook County, which is about 2/3 of the state in population. And we're going to ensure the diversity, equity, and inclusion requirements. So really making sure faculty, staff are diverse in our leadership and throughout our Cancer Center membership. And then also things like clinical trial diversity is examined and graded. Like all of these things drive not just your score and but it drives the amount of funding, not just funding, the amount. So those are types of things, those are structural things that can be modified to drive how we do research or how we set things up, right? This is implementation science that I'm telling you. I'm walking you through process, right? And then think about it. Who gets to be a PI? Who gets to be a scientist, right? Who gets to go to some schools and be at some institutions that are just, level 1 research, high research institutions versus lower research funded institutions, right? And who gets to be those PIs? Who gets to get a career award? Who gets certain mentors versus others? All of those processes matter with respect to diverse workforce, which then also impact what kind of research is done and who the research is done with, right? Same with the protocol design, exclusion criteria can systematically, I see it I serve as a health equity committee chair for ECOG Akron, which is one of the NCI research bases and core research bases. And you see it all the time, how protocols are designed and they'll inadvertently or advertently exclude some versus others. And so then again, that's who you get to participate in the clinical trials. Okay. Now, Abbott and other pharma companies are thinking about this right now with respect to open clinical trials. Right, all of these things, process matters, design matters. And you all know a lot about community participatory research, who participates in the study design, who participates in the data collection, who participates in the analysis and the dissemination. So I already touched a little bit on diversity matters in clinical trials. We know that about 13% of the population of the United States is identified as Black or African American, and only about 5% participate in clinical trials, and then about 18% of the population identifies as Latino, and about 1 to 2% of clinical trial participants. The other thing we have to think about with respect to process is access to care. Access to care is more than just health insurance. It has all of these different domains, right? There's quality and consistency of care, receipt of guideline concordant care. In the lower left-hand corner, you see the diverse workforce that I've talked about and biased mental models within that diverse workforce. Now, we're not going to train our way out of racism, but understanding that biased mental models exist, there are ways to address that and train, like the pause model. You can look it up online, that's a good one. And then things like financial toxicity, well-being, insurance status, payer policies, reimbursement. How are we really thinking about reimbursement with respect to the community resources that we connect our patients to when we've identified social determinants of health, right? In EPIC, when that pretty little circle pops up on the screen and you have all these social determinants of health identified, then we refer people to resources, but then what happens? And do those resources get reimbursed at the same way a hospital would? And how do we actually figure that out, right? And then in the upper right-hand corner, all the other things that I talked about: health literacy, language, location, rural, suburban, urban, social determinants of health, et cetera. And then again, stigma, discrimination, and experience of trust or distrust, experience of discrimination in a particular clinic or healthcare system, or just in the healthcare system in general in our country, is transferred over generation, right? And your family and your friends, if you or your family or your friends or your sister or your brother were wronged in a particular institution, what makes us think that the rest of them are gonna come to our institution, right? So that trust, like I talked about earlier, is really critical to build back. So implementation science has a big promise, right? To close that science practice gap and really try to get things moving more for more populations, more places, more people. This is just one of a billion frameworks for implementation, the consolidated framework for implementation research. I think it's the most simplistic one, because really most implementation models really just want you to think about what's that inner team, who's on what base, who's on first, who's on second, who's on third, right? How are they working together? Is that base coach, is the second base coach like really working to make sure that second baseman is doing well? Like, is everyone thriving in that cell, right? And is that cell then able to make a beautiful symphony, right? And how is that inner team working with the outer setting, whether it's the higher up health system, the leadership, the policies, practices? And then when you deploy a new intervention, right, that process is iterative, back and forth. And how does that work? And where are the opportunities for bias or racism or other isms to creep into the process, right? So all of that's important. So this is not meant to be read. But during COVID, I participated on one of the National Academy of Medicine's or Science, Engineering, and Medicine's roundtables on obesity solutions. And we really thought over a period of 3 webinars, they're recorded and available on their website. But it was to really think through what would it take to really decrease obesity in this country. Like, what would it really take? And that's what we came up with. We laugh, but that's the truth, right? When I'm talking about these trees being bent and these processes favoring some and actively disadvantaging others, that's why. Because people are in their own silos, right? They're all, and everything is dependent on each other. And with respect to obesity, there's a lot of things, right? The environment, food, all of the policies that impact that, and exercise, whether there's availability of medical care, like there's all of these things, schools, all of these things impact obesity. So I know it's mind-blowing, but when you are trying to think about process and practice and implementation science, you can't just think about the implementation of one thing isolated. It's one thing that's connected to another thing that's connected to another thing, right? So in terms of Chicago, you may have seen these data before, but we knew, right, in Chicago, we have, and we still to this day have terrible cancer disparities, right? Black, white, prostate, breast are some of the more prominent ones. But, you know, this was just one example. And I worked with Dr. Whitman back in the day, looking at data. It really showed that the mortality, these are black-white mortality rates, 3-year age-adjusted aggregate breast cancer mortality rates between 1981 to 2007. And in the early 1980s, that magenta line are the black women, and the gray line are white women. And there was about the same mortality for breast cancer in the early 80s. But something happened in the 90s where the line started to diverge, and by 2007, black women in Chicago were dying at a rate 62% greater than white women. And this is an important story to keep telling over and over again, because what is wrong with Chicago? Because if you looked at the rate difference, the mortality difference in New York was about 26%, and in the United States it was about 45 or 46%. So what was wrong with Chicago, right? And it certainly wasn't black women being different in Chicago, right? Chicago is definitely one of the most, not the most, but one of the most segregated cities in the country. Has a lot of inequities and decades of redlining and systematic disinvestment in certain parts of the city, right? And so it's really important to understand the why, right? Looking at social ecological model, really thinking about all the different levels of that complex obesity systems map kind of approach, but in a more simplified way this way. Like there's interpersonal barriers, right? The distrust and fear and the inner circle, lack of knowledge, access, all of those things nested within community barriers, right? And then nested within health system barriers and nested within policy and practice barriers, right? And so solutions included things like patient navigation, implementation science, process quality improvement, and advocacy and policy. So patient navigation, interestingly enough, is not just an intervention, but it's an implementation strategy. And that's a really important point. Because back in the day when we started patient navigation, and Julie Darnell was here, because I started way back with her, here, well, down the street at UIC. Patient navigation was more of just an intervention, or, you know, community health worker, promotora, right? One-on-one. Let's get this patient connected to a patient navigator and we'll solve all the problems. Well, the thing is that patient navigation, as great as it is, and as evidence-based as it has become, right, an evidence-based intervention, it is an EBI, but it's a Band-Aid, right? If you just think about navigation, patient navigation, or community health worker, just, you know, as an intervention, it's a Band-Aid to plug up our terribly complex, convoluted healthcare delivery, right? And all the gaps, and how all the processes are so complicated in helping to address the social and economic determinants of health that patients have, right? All the barriers to care that we identified back in the day in the early patient navigation research program that even Harold Freeman, who I work with, identified, right? But if you think about it, it's also an implementation strategy. So from that point of view, you can look at patient navigation as a learning health system, which we should be doing. What are all the actions cumulatively that a patient navigator has to do on behalf of a patient and on behalf of the healthcare team, right? So how is that an implementation strategy, right? So then if you start to identify, right, the cumulative things that patient navigators and community health workers are doing repeatedly over time, then you can start to think about the process, right? And then think about how you can improve the process so you don't need the navigator to do that same thing 5 billion times, right? People are walking with me. I can see heads nodding. The other thing that we did a lot of So I worked with systems engineers who did a lot of environmental scans, and what they did was follow women across many different medical centers, mammography centers across the city, and they actually documented every single action from the time a patient went into a clinic to the time they left with a mammogram referral, and documented all those processes. And then fed them back into clinics to help improve that consistency and quality of care across the city. But also what we found was checklists are really important. Now checklists, when they don't have something on them, that's a problem. But this took time, a lot of different iterations. This is just one example of many. We have checklists for lots of different things. But this is a 4R sequence. Breast cancer surgery first. But what we tried to do is can we take what the navigator has been doing and put it into a checklist, so we put it all onto one sheet of paper. Literally, this is a piece of cardstock, and there's a front and a back. The back just has phone numbers on it and contacts, and then kind of create a Gantt chart so that people have, patients and their loved ones have kind of an idea of the overall care plan, right? To make it as simple as possible, yet as comprehensive as possible, so that when there's a box that's not checked, it will allow anyone, regardless of their health literacy level or their level of trust or language proficiency, to actually say, why isn't the box checked? It's a simple mechanism to try to impart or embed agency on behalf of a patient in a healthcare and a very complex healthcare team, right? If we're trying to do if we're trying to deliver patient-centered care, then thinking about a process to make it as centered and as simple as possible when it's so complex, cancer care is super complex, right? You could create a checklist whereby the patient or the caregiver, loved one, whomever, can say, hey doc, you haven't helped me get the dental consult yet. Why isn't this box checked, right? And that will spark a conversation, right? It's a very simple thing, but it's one of those things that we've been trying to figure out how best to embed equity into the process at a more of a macro level. And so this is what we've been playing with now in survivorship care as well, and in care when we graduate, so-called graduate patients from our comprehensive cancer center back to primary care. That's when this is really helpful, right? Because the primary care team gets that patient who just spent months at Lurie Cancer Center, and now what do we do, right? So it's an idea. So through a very collaborative and iterative effort, just so you know, the reason why I showed this is just to show that navigators, community health workers, also connect agencies to each other, right? So thinking about the process of not just connecting patients to individual resources, but what we found in our DuPage County navigation, for example, and in our Chinatown navigation program now, that's been going on for over like 12 years, is that the agencies, by just the virtue of navigators taking patients and helping them get from resource to resource, the resources are starting to share with each other, which is what we want them to do, right? And that helps improve effectiveness of each of the agencies. It helps get their reach, which is an important marker for their own funding, more spread out and connected, right? So that's another important point of process. So through a lot of collaboration, we know that Chicago was able to close the mortality gap between Black and white women to about 36%. And that stayed till right before the pandemic. We don't know very much what happened in the pandemic, but we will see. This is it's still not good enough to be at 36% or so difference in mortality, but it's better than 62. But that success was predicated on a lot of things, right? There was the Metro Chicago Breast Cancer Task Force that was now called Equal Hope. There were bills that became laws in our state, not only that had patient navigation embedded in them, but people got higher reimbursement rates for mammograms to the Medicare rate from the lower Medicaid rate if they shared quality data. There were a lot of things, and there was a whole lot of media that was associated with that. And we all know that in Chicago, in the windy city of politics, media is very important because aldermen and mayors like to make data go away. You can't make data go away with a magic wand. You have to make a stink. And so that is why science and the collection of data is so important to driving changes in policy and practice. And then we have the Chicago Cancer Health Equity Collaborative, which has helped in many other types of cancer inequities. We have this is since 2015. This is a collaboration between Northwestern Cancer Center, UIC, and Northeastern Illinois. And we do a lot of different programming. We also work with the Chicago Public Libraries. And we've been doing this for several years now and have the Health for All Real Talk on clinical trials. We have a variety of programming in the Chicago Public Libraries around clinical trials, dumping out the myths about participation. We have modules online that are free and available, little vignettes and videos on just stomping out different myths and telling people who are interested in trials what their rights are, what a trial is, kind of just going through the basic clinical trial health literacy. And then we've trained librarians on clinicaltrials.gov. We also have this for preventive services as well. We also have a community scientist team that informs research projects. Most recently, our community science team has visited a few different early translational science teams in our cancer center and asked the question around metals. Why, they were worried that metal exposure was really bad for cancer. And indeed it is. And we know in Chicago that those decades of disinvestment and where the alignment of things like the major highways are in certain neighborhoods in Chicago, then increased exposure to diesel fuel and other toxic waste sites, that some people in Chicago have higher levels of metal in them than others. And that actually is really important for cancer treatment. So certain cancer treatments, like in breast, prostate, others, that some of our scientists are studying, if you have a higher level of certain types of metals, it actually makes you resistant to certain types of our usual therapeutic approaches for certain cancers. And so that could be driving some disparity too. So sure enough, since this fall, we've been out in the community fairs and communities doing cheek swabs in certain communities. And people are so excited about this project that the community scientist team brought to the bench an early translational science team. And now we're bringing these diverse cheek swab samples and self-report surveys into the bench. And we're analyzing them now and then trying to get more funding to make this a more thoughtful, bigger project. But again, that's the power of connecting T4 and community back to the bench, right? And now the bench is going to drive some of the results, and the community scientists are going to help. It's going to go back and forth. So again, we can do this in maternal mortality as well. So I have a few more minutes of presentation, but again, thinking about process and implementation, right? We know that maternal deaths, about 80% of maternal deaths in this country are avoidable. Our maternal mortality rates are embarrassing. They're the worst in all high-level, high-income nations on this planet. And we know that there are about 69.9 deaths per 100,000 live births for Black women in this country, and about 28 deaths per 100,000 live births for Hispanic women in this country, and that's an all-time high. There has never been an all-time high for Hispanic women in this country to be dying. We are usually below the rates of white women, not Hispanic white women. So this is a time, like there's a problem here. So we have 2 implementation science grants going on right now in Chicago and in other sites across the country. We are looking at perinatal care. Perinatal care really hasn't proven to improve outcomes, but perinatal care was never designed for anyone other than white, non-Hispanic women. That's the original ACOG Hollister form, how we collect, like, because in clinic in obstetrics, we have a checklist. Very basic, right? You come into your prenatal care visit, we put you on the scale, we take your blood pressure, we listen to the baby's heart rate, we measure your belly, and we say goodbye, right? I mean, there's a little variation in there, but that's in general what our checklist encompasses. And then we have this list of labs, blood work you need, constantly your blood taken in pregnancy. But we never really thought about how do you engender trust so that we get you into prenatal care earlier, right? And then we get you to come back multiple times if you trust us, right? And thinking about where else care could be provided if you can't get to the clinic. So all of these things, right? So what we're testing right now in Access Community Health Network clinics and Alliance clinics across the city is, can we change the cadence of visits, right? So we did a lot of qualitative research during COVID around Black women's experiences of pregnancy and birthing and all those things, and providers' experiences as well, and then fed them into, can we retool the cadence of visits, right? Because it's 9 months, that's a lot of time. That's a window of opportunity to impact somebody's health and future health and their family's health. And then can we start, instead of with the first prenatal visit, which is a basic dump of information about everything, and just start with trust. And what would be those trust questions? So has anyone ever, when you go to your annual well person visit, has anyone just stopped and said, you know, what are your hopes for your health for this year? What's your goals? What's your hopes for your pregnancy? What are your fears? How can we help you? And just, has anyone just chatted like that before they like attack you with needles and blood pressure cuffs and a scale, right? You know, so we're actually testing that. And then we're also testing a check-in like at 1 week postpartum or 2 weeks postpartum, and then different ways to do that, both telehealth and in person. So that's what we're doing in this one. And then in the Well Mama Doula project, we're actually, which is at Stroger Cook County Hospital, Baton Rouge, Louisiana, and Newark, New Jersey. And we are really looking at, can we distill a priority checklist of the top 5 reasons for avoidable maternal morbidity and mortality? Avoidable. So mental health issues, cardiovascular symptoms, headache, high blood pressure, floaters, safety, opioid substance abuse, and social support. And can we do that in different places and spaces? Imagine if you showed up to Walmart and you're pregnant and you haven't been to a healthcare provider, but somebody gives you the opportunity to get your blood pressure checked at Walmart, and someone gives you this survey to fill out, 1 question to 2 questions for each of those 5 things. And it triggers a positive sign, which could then help connect that person, that pregnant person, to a healthcare provider right then and there. Right, I mean, thinking about process, right, and how we can modify things, especially in places like Baton Rouge and Newark, where there might not be ready access to healthcare. So all of this stuff has been, you know, you don't do research in a bubble. You've got to influence policy and practice. I'm one of the people who work with Congresswoman Underwood, many people do, but to help inform the Momnibus, and now we're on 2.0. And because of everything that's happening on the Hill right now, 2.0 probably isn't going to go through anytime soon. But if you want to see a set of bills that I would say are a great example of addressing social determinants of health, I would say the Momnibus is a great example. So many of you are teachers and influencers and interested in policy. This set of bills is super comprehensive with respect to being thoughtful about addressing social determinants of health. I think this is a really good example to think about, and how then can the research that we do in each of our own individual teams and labs, how we can influence policymakers, right, to create sets of bills like this, regardless of if it's in cancer and in maternal mortality, whatever it is. If this is a possibility, there's numerous other possibilities to create bills like that. And the other thing is workforce development. So I'm really proud to say that we do a lot of that in our Center for Health Equity Transformation. We have many different types of programs and pathway programs. I don't believe in the word pipeline, I like pathways, just availing more opportunities. We also have an NIH FIRST grant called Nurture, and that is one of those competitive NIH Office of the Director initiatives to actually increase underrepresented faculty in the workforce on tenure track. So we're hiring 15 faculty under that, tenure track faculty under that new grant that just started in September. And then we have all the other training programs like T37. But all of that is important. And finally, civic engagement is important. Like I said, those policies, we have to be willing to commit to change. We have to combat disinformation and distrust. And voting is important. And not everybody gets to vote. So Healthy People 2030, I don't know if you all know, it's going to include increasing the number of voting age citizens who actually vote as a health indicator. So stay tuned and watch out for that. Very exciting. So in conclusion, we need to be strategic and intentional. We have to make good trouble and look under the hood of the car and get that orchestra to make a beautiful symphony, right? Looking at the implementation and the process and iterating, right? And being more civically engaged. So it is the we, not the me, and we want that ecosystem to work for everybody. So thank you so much. I'll take questions. I stopped sharing. Oh. I don't see any in the chat.
I'm in the chat department.
I love your new initiative about health, right, and going I had experience when I was practicing medicine. I got to work for a year in a community growth, and that was my problem, right? People not getting out of school, right? So you need to get out to the community, and I can understand a lot of people. Have you explored a member of the community that there's always a mom or a old woman that take care of the each winter? So and partner with one of them, and it was it's kind of
Yeah, I think this comment for the online people was that, partnering with influencers and key people to connect, to build that trust, to help bridge trust is really important. I agree with that. It's the same in community engaged research, right? Partnering with, building the relationships and connecting researchers to community partners. But you got to trust the research team, right? I'm not going to just connect any research team to my valued community partners. I've built those I built those partnerships for a very long time, right? But it's about showing up, saying you're going to show up, doing what you say you're going to do, and if you can't do it, being honest about the fact that you can't, that it's not going to work this way, but we can try this way, right? And that long-term commitment. But yes, I agree. Having like partners to help bridge communities and practice is really important.
Thanks, Melissa. I really appreciate you being here and coming back to your alma mater. It's great to see you. And an excellent presentation. So I always have a question around implementation, and especially around your stories, around like work that's developed around community navigators and thinking about them in different ways in a process. And one of the difficulties is the rapid two parts. So one is struggle in large systems that are learning systems, where things are constantly changing and now even more rapidly changing. How do you ever do a clinical trial that can work? Because fundamentally, by the time that trial ends, the process has changed.
Right, but you're documenting how that process is changing. So I do a lot of hybrid trials, right? So we're looking at the intervention itself, and then we're looking at the implementation of that intervention at the same time. And obviously, in a type 3 type hybrid trial, you're looking at more the implementation, and you have more implementation measures to examine, and less about the intervention itself. And type 1 is the extreme opposite. But I think that's important because you're never at the same place that you started. And that makes people who are purists around RCTs, clinical trials, it makes them really sick to their stomach. But you've got to do that. Otherwise, you cannot be pragmatic. Things don't fit in a bubble. And that's part of the messiness of when we look at a higher level at like things like what creates recommendations, right, and grades, like for the USPSTF work, what is the actual gold standard RCTs that are required in order to get that recommendation grade down. And we've gone back and forth about that. And that's why there's a lot of modeling involved in a lot of those big recommendations, because it is messy and there aren't good RCTs for everything and every person, right?
Yeah, that was going to be my second point, is the contextualization, right? Like it works in one system, it won't work in the next system across the street. Exactly. Or one clinic in one community, but not in Alabama, for example. So hopefully, I'm hoping that methodologists, as we move forward in implementation science and others, start to create and work with statisticians and really try to innovate in some of those things, in those approaches, because it is really messy. And especially trying to do these trials through COVID, nothing is the same. It was not consistent early on, for sure, when we pivoted, because we started the trial, COVID hit, and then we had to pivot, and then we now are back, and it's
There is the old story about how many psychologists does it take to change a light bulb. Only one, but the light bulb really has to want to change.
Yeah.
The allegory is, does the healthcare system and its funders especially want to change?
Well, I think that depends on who the leaders are and how those leaders are chosen. The same pathways, more of the same kind of characteristics, same leadership traits, same background, chair of medicine, whatever, going to be dean. I think those are important points. Like, I would say we're standing on Russia's territory. I would say Russ is doing a really good job of trying to innovate and be thoughtful of how to move forward in terms of the health system want to change.
So in Texas,
okay,
for example.
Yeah, that's a good example.
Yeah. you know, I hate to bring up politics, but I don't hate to bring up politics because that's what this is about.
Right.
Politics is why there's systemic racism. And the history of politics. So,
And how people vote and who votes, right? Who votes.
exactly.
Yeah.
So how can we, is there pay dirt in tying, voting to health? Apparently, the Surgeon General's office thinks so.
Mhm.
I presume that Healthy People 2030 comes from that. But is there evidence that, you know, half of Congress thinks similarly?
Is there evidence? Well, I think our policies around women's health right now is evidence that the majority in like the Supreme Court and how states' policies with respect to abortion kind of play out. I would say that's evidence, right?
Yeah.
So, you know, there seems to be a full throttle attack on people who can get pregnant in this country, and until people stop voting on issues such as abortion, politicians are going to use the abortion word to their advantage to gain office or continue to stay in office. So that's how I see the connectivity, for an example of connectivity between politics and healthcare policy.
So,
Now I just got people raising hands. Here we go. Now we've opened the can.
as an implementation project, one approach to changing this is to have wholesale political activism to make things the way we prefer.
Well, I would say the FDA's vote, that committee's vote, was it last week? Yeah, for the O pill. So for the, there are about 100 countries on this planet that have over-the-counter access to birth control pills. About 100 countries. And the United States does not have any. And that committee for the FDA, it's not official yet, right? Because there's still has to be the final vote sometime in mid-July or so for the O pill, which isn't even a fully real birth control pill. It's all progesterone. I mean, it's a real one. Don't misquote me, but it has no estrogen in it. It's progesterone. It's not going to hurt you. Tylenol is going to hurt you more, you know, than the O pill. So we're moving towards at least something, right? There's some hope, right? Mifepristone was another thing. Like, again, another medication that is not going to kill you yet. You know, we have Viagra that's covered, and got the issue with mifepristone and over-the-counter birth control pill access. And so, you know, there is a full throttle attack on women's health and in general, or people that can get pregnant. All right.
So I just noticed that you started your presentation defining some terms for us.
Mm-hmm.
So I'm assuming you're about words and concepts. And DEI is, for some in the political universe, is being substituted for belonging.
Mm-hmm.
Have you thought about how this change in terminology changes health outcomes? How are you thinking about this, and what are you doing about it, if anything?
Yeah, I mean, it's not a substitution. I think belonging is part of the continuum, but you gotta first have diverse people, and then you gotta create the inclusive environment, and then you gotta actually value the people that you brought to the table or onto your team, and actually create the ecosystem and environments that allow everybody to feel like they belong. So there's like, I see it as a trajectory, and it's not, you know, necessarily linear, but it's an important part of the process. You can't just get diverse people to wherever. One of my huge pet peeves I'm dealing with right now is that I do a lot of mentorship and have a lot of programs that bring very diverse people into medical schools, including our own, and onto nursing schools, graduate schools. But then I get the feedback from the students I've placed, and they're like, they promised me scholarships and financial aid and all this stuff, and they're not giving it to me. So now how am I going to pay for it? That's just one example. Or this environment is not friendly. I don't feel comfortable here. I'm one of only, right? And so that belonging piece becomes really important, especially when you start to get in the higher echelons of the professions, like, you know, PIs, scientists up through that academic pathway, professor level. It's like, only one. Where is everybody? Same thing in professional schools. When you're the only, right, ENT doctor of color, or, right? So belonging is really critical. We do have to think about the ecosystems in which we're placing people, and if we really do want to operationalize diversity in the most thoughtful and comprehensive way, we got to think through that whole process. But most of us go through life and don't feel like they don't belong on a day-to-day, hour-to-hour basis. When you flip the coin and you are the one of only on a day-to-day, hour-to-hour basis, it is exhausting. It's traumatizing, it's re-traumatizing, it's stigmatizing, it is exhausting. And the people in power who create the ecosystems, who are supposed to create this DEIB belonging, do not think through what it's like to be the one of only or the one of few on a day-to-day, hour-to-hour basis. And if I had one wish, that is what I would wish for. And that gets back to the fundamental question, do healthcare systems want to change? Well, because they've never been on the flip side. Good question.
Yeah, and I'm having a hard time articulating it.
Okay.
The slide that I found so powerful was yours, and it was just the chart about the funding pathway and the creation of funding opportunities. Mm-hmm. And understanding just how powerful that pathway is, mm-hmm. And what you said about the fact that is the real exercise of power that happens through funding pathways. I think everybody in this room has experienced that firsthand. Mm-hmm. Like the moment you pick up the funding opportunity, you read it, you immediately are following instructions, and you're going to do it because you want the money.
You're real fast.
But it's in that context, then it makes our political climate here, politics again, seem so much more sinister. Because you suddenly start to see, you know, people working very, very carefully and very strategically, mm-hmm. to make sure that the people who have those, you know, that they can, you see it in Florida, like you don't say gay, or you know, mm-hmm. the undermining of voting, it's all about that exercise of power, and in a very, very specific way. Sorry, like I said, there was no.
It is. It's about gatekeeping.
Yeah.
Yeah. I have a slide that I didn't put in here, but yeah, it's about gatekeeping. Same thing in publication. I'm a new associate editor at JAMA, and you know, it is about gatekeeping and how those processes are laid out, because publication has a lot of bias too. And yeah, I don't mince my words at JAMA, so. Don't worry. I just started though, so you know I might get fired. I'm only day 19.
But I mean, how are we going to, like, clearly there are people who are working in a very strategic way on this.
Sure.
I worry that we're not being as strategic.
Well, you know, the point is that everybody can weigh in and do their part. And it is about, you don't have to move a mountain, right? You can just, in your own world, think about how you do things, right? In your own clinic or your own team, what are the policies? What are the, are there opportunities to maybe modify certain things? Who do you get onto your team? Or what kinds of research questions do you ask, or who you involve in that research? I mean, there's a variety of ways to do it. It's just, if everybody does kind of their own part, then eventually that map that I showed for the obesity solutions, it will happen. But it takes everybody kind of being more aware of that process and about that belonging and about what it feels like on a day-to-day basis to not feel belong, like, as part of, or valuable. So I think I'm not here to tell you this doom and gloom, but the glass is half full. I think we're at time. I don't even know. I don't see.
We're past time. Thank you all very much. And thank you for our online audience who have been dropping off steadily, but thank you.
Yeah, there's like only a couple people
Yeah.
left.